Hello, everyone. I'm Warren Jones. I'm a family physician, and I have the honor of serving as chair of the National Forum for Heart Disease and Stroke Prevention. I want to thank each of you for joining us today for the National Forum's mid-year virtual convening. Our sessions today will focus on the Surgeon General's call to action to control hypertension. Now, thanks to you, the National Forum has evolved from a meeting in 2002 into the recognized, respected convener of public, private, and nonprofit sector organizations that we are today. Our efforts focus on shared commitment to improving the cardiovascular health in the communities we serve. The dialogue that we engage in leads to ideas and sparks cross-section collaboration, leading to improved health outcome within our communities. Now, 7 months ago, the Surgeon General issued a call to action, urging all Americans to recognize and address hypertension control as a national public health priority. That call to action provides useful strategies that are proven effective in addressing costly, dangerous, and far too chronic health conditions that are related to hypertension. We've come to know that there are significant racial, ethnic, gender, and age differences in the prevalence of hypertension and the rates of blood pressure control. For example, African Americans have much higher rates of hypertension than any other racial or ethnic group. The sad part is many also have poorly controlled hypertension. I've got to confess to you that controlling my own hypertension isn't easy, but my family physician and I work on it on a daily basis to make sure that we keep it under control. Now, everyone can improve blood pressure control by taking deliberate steps to address and eliminate the barriers to our success. Barriers such as the social determinants of health. Removing those barriers is necessary to help people in our communities better manage and improve not only their blood pressure, but their overall health. The truth is, blood pressure control is possible. And working together, we can achieve it. Today is a good step in that direction. And again, I'd like to thank you for joining us. I'd like to ask John Clymer, our Executive Director, if he will introduce our first speaker. Thank you again for being here, and I hope you find today helpful, useful, and enjoyable. John?
Thank you, Dr. Jones. During today's convening, we ask that you share your experience via Twitter and Facebook. The social media handles are all on the screen. Before we begin, I want to encourage you to submit questions at any time during this meeting by using the Zoom Q&A button. Answers will be posted together with the meeting summary and slides on the National Forum's website. Please use the chat function to offer comments and information throughout the convening. And now, I thank the National Forum's contributing members whose support makes today's convening possible. They include Amgen, AstraZeneca, Bristol Myers Squibb Pfizer, Esperion, Johnson & Johnson, and Novartis, and Spark 360 for its in-kind contributions. Over the last 15 months, America and the world have heard the U.S. Centers for Disease Control and Prevention provide guidance on protecting people, communities, and the nation from COVID-19. Even as the pandemic has gotten most of the airtime in newsprint, CDC has been hard at work to address non-infectious diseases that were too prevalent before COVID-19 and the inequities associated with them. Dr. Karen Hacker, Director of the National Center for Chronic Disease Prevention and Health Promotion at CDC, has been leading these efforts. We are pleased to have Dr. Hacker with us here today. She has extensive experience as a researcher at Harvard and as a public health practitioner as the local health official in Allegheny County, Pittsburgh, PA. Dr. Hacker?
Thank you so much, John, and a pleasure to be here today. Today, I'd like to discuss the importance of recognizing how COVID-19 has affected chronic disease, and more specifically, cardiovascular disease and hypertension. We know that certain health conditions and chronic diseases put people at higher risk of developing severe illness from COVID-19. Heart conditions such as heart failure, coronary artery disease, cardiomyopathy, and possibly high blood pressure or hypertension are all conditions that put people at risk for severe complications from COVID-19. Data from June 2020 show that hospitalizations were reported 6 times higher and death 12 times higher for COVID-19 patients who had underlying conditions. Cardiovascular disease was the most common underlying condition at 32% of reported conditions. Hypertension affects tens of millions of adults in the United States, more than 116 million of us, and the control rate is less than 25%. And disparities in control rate abound. In addition, many people are unaware they have or are at risk for hypertension. COVID-19 has revealed many barriers and challenges for monitoring and controlling chronic diseases, including hypertension. And despite the relationship between cardiovascular disease and COVID-19, the pandemic resulted in a decreased use of healthcare services for emergencies and for ongoing prevention and routine healthcare. Due to the pandemic, many people were unable to access important management tools and treatments for their hypertension, such as blood pressure monitors, medications, and healthy food. People also had less opportunity to be physically active, a trend which can result in higher rates of obesity, overweight, and hypertension. Data have also shown that rates of alcohol consumption have increased during the pandemic, and alcohol consumption is a known risk factor for hypertension. Due to the increased stress from the pandemic, we may also see an increase in smoking rates, another risk factor for heart disease. Many of our state programs and resources dedicated to heart and brain health were challenged by the demands of the pandemic. The lack of access to preventive services and treatments for hypertension means we will potentially see an increase in the number of adults with uncontrolled hypertension and a further increase in cardiovascular events, including deaths. COVID-19 affects the cardiovascular system, care, and outcomes, and has done so inequitably. We know that chronic disease risk factors for chronic disease and COVID-19 all tend to disproportionately affect people of lower socioeconomic status and certain racial and ethnic minority groups. As a result, Black or African American people, Hispanic or Latino people, American Indian or Alaska Native people, and Asian Pacific Islander people are all at higher risk than non-Hispanic white people of getting sick, being hospitalized, or dying of COVID-19. High blood pressure is more common in non-Hispanic Black adults at 54% than in non-Hispanic white adults at only 46%, non-Hispanic Asian adults at 39%, or Hispanic adults at 36%. And across all subsets of US adults with hypertension, the rate of control, defined as less than 130/80, is extremely low. By race, 13.2 million, or 81.9% of non-Hispanic Blacks, and 58.8 million, or 77.8% of non-Hispanic whites, 12.9%, or 85.6% of Hispanics, and 5.6 million, or 86.4% of non-Hispanic Asians, and finally 2 million of others have uncontrolled hypertension. Although we cannot yet predict the effect of these trends on control of existing conditions, we do know that 4 in 10 Americans surveyed in June last year reported delaying or avoiding medical care during the COVID-19 pandemic for both routine and emergency care. Delaying or avoiding urgent or emergency care has been even more common among persons with underlying medical conditions, Black and Hispanic persons, and people with disabilities. And the extent to which control of chronic disease might mitigate a person's COVID-19 risk is still largely unknown. But we do know that appropriate management of chronic diseases, including hypertension, can save lives. So as we see progress against the pandemic, a backlog of critical chronic disease care will still need to be addressed. This backlog could result from the neglected emergent care, delayed preventive care, missed screening, missed treatments, lack of medication, changes in healthcare access, but also economic hardship. The underutilization of these preventive services may have an even greater effect on people disadvantaged by pre-existing disparities. And for many, the effects of the pandemic on access to primary care practices and other healthcare settings and a lack of community resources may be of particular concern. So what we know is that throughout the COVID-19 epidemic, a great deal of anxiety has surfaced about safely accessing healthcare services. Healthcare providers have adopted a wide variety of strategies, though, to mitigate risk, including increased social distancing, like limits on waiting room capacity, mask wearing by all people in healthcare facilities, screening of patients for COVID-19 symptoms, and in some cases, for actual infection, and expanding the use of telemedicine. Patients now have a range of options for safely receiving care and should ask and be informed about these options when making their appointments. Telemedicine options can help streamline access to needed care, but these options depend on digital access, which is also likely to be most problematic for older people, those who are of lower income and with fewer resources, and people in rural communities. The pandemic's total impact on hypertension and cardiovascular disease is still largely unknown. We will need to research how chronic disease has been affected by the loss or lack of health insurance, stress from the pandemic, the time spent at home and its effect on mental and emotional and physical health, the lack of access to healthy food, the lack of follow-up care, and the loss of medication regimes. We also do not know the long-term impact that this will have on people who get sick from COVID-19 and have underlying or COVID-related cardiovascular disease. Cardiovascular care has always been essential, and providing this care has become challenging during the COVID-19 pandemic. We must improve awareness and encourage utilization of needed care. Otherwise, we may find ourselves absolutely overwhelmed by poor health outcomes when the pandemic is over. This work will require innovative approaches from a healthcare system perspective, but also from a public health system that have to balance the risks and benefits during the pandemic. And even more importantly, it will require a concerted effort to address the social determinants of health, which have been compounded by the COVID-19 pandemic and which we believe are driving today's health inequities. Ensuring health equity for people with and at risk for cardiovascular disease is central to our mission at CDC, as central as it is to the National Forum. Thank you so much for joining today's session. It's been a pleasure to speak with you. Thank you.
Thank you, Dr. Hacker. Some people call the next speaker our nation's leading expert on brain health and stroke. He is Dr. Walter Koroshetz, the director of the National Institute for Neurological Disease and Stroke at the National Institutes of Health. Prior to coming to NIH, Dr. Koroshetz was a distinguished physician scientist at Mass General and Harvard Medical School. I am pleased that he is the NINDS liaison to the National Forum Board of Directors. Dr. Koroshetz?
Well, thanks very much, John, and thanks to the National Forum for giving us the chance to talk about this important message. What we're going to tell you today is that brain blood vessel health is primarily related to blood pressure. And if we can get rid of hypertension, that will do a lot for brain health. And so the brain is a complicated organ. It is really responsible for everything that we do, our thoughts, our desires, our emotions, our activities. And it's like a massive computer, and it works on amazingly small quantities of energy, but energy is incredibly important. The brain cannot work without a steady flow of energy from the bloodstream. And what that means, therefore, is the blood vessels, which you see here in the lower left, are incredibly important, and they're producing flow into these brain areas that you see here on the right in response to activity. So when you talk, or an area of the brain will require more activity, more blood flow will come. And so it's a very intricate pattern that's responsible for what you can do. And unfortunately, as our brain vessels age and become sick due to hypertension, this process really goes awry, and that has effects to cause stroke, which is damage to the brain, and actually cognitive impairment, which is probably very common due to hypertension, but is kind of a slowly progressive, kind of silent epidemic. Now, the issue with hypertension is not subtle. We know for a long time, these are studies from my mentor, Dr. Miller Fisher, back in the 60s. And what you see here is a blood vessel. It should be wide open. There should be blood flowing, but it's completely blocked by a scarring process that goes on in the blood vessel wall and leads to the blockage of the blood flow and eventually a little stroke. These small vessel strokes are what they've been termed. And this is all due to hypertension. You don't see this except with hypertension. On the other side here is another slide from Dr. Fisher. This one is a microscopic slide. This one is just a regular photo of a piece of brain tissue. And you can see there's all this whitish material. Some of these are like wide open lakes here. That's a stroke. But throughout these fibers, you can see this loss of the gray staining in what this is actually called the white matter, even though the stain is black. But this loss of the stain here is what we call diffuse white matter disease. So the combination of these strokes and the pallor of this myelin stain for the white matter is what we call white matter disease. And that's really one of the major issues we'd like to get out in front of the audience, that this is going on in many of us and is related to hypertension and is related to cognitive impairment, and something that we think we can do something about by doubling down on hypertension. And there are many different theories. We don't understand all about the white matter disease, but as you can see here on this MRI scan here, all this white stuff here, that should not be here. That's white matter disease, and it's very common. It probably affects 80% of people over age 80. So it comes with age. It's worsened with high blood pressure. The higher the blood pressure, the worse it gets. And the thought is that from this theory is that it's due to increased pulsatility. So the blood pressure, remember, the heart is pumping and you get this massive pressure when the heart contracts and the blood goes into these small blood vessels, and then the heart relaxes and then the pressure goes down. So that pulsatility, that difference in pulse and that pressure on these blood vessels, what causes the wear and tear over time, leads to this white matter disease, and then also to stroke, as I showed you with these small vessels becoming blocked. Not only do they become blocked, but sometimes they also develop a defect in their wall. You can see here, here's a small blood vessel, but here's actually a little clot of blood, a microhemorrhage that occurred due to the damage to this wall due to the hypertensive changes. And here on the MRI scan, you can see these tiny black dots at different places. These are called microhemorrhages. These are common. People don't know they have them, but they're signs of this really destructive process on the small blood vessel wall. Unfortunately, some of these hemorrhages get pretty big. So this patient had a fairly sizable hemorrhage. It was not fatal, but unfortunately, a good number of these hemorrhages are actually fatal. And even this one could lead to some severe loss of strength and coordination on one side of the body. So hemorrhage is another problem that's related to the high pulsatility, the breakdown of the wall of the blood vessel, and leakage of blood out into the brain, which is not a good thing. Now, for years, since 2016, NINDS has launched and looking for partners, has had great partners in the past, what we call the Mind Your Risk campaign, to raise awareness about the link between high blood pressure and dementia. And we'll talk about that later, but the main theme here is that white matter disease that I showed you, as it gets prominent, it is associated with cognitive decline and probably also dementia. So the idea here is that we know that that is related to blood pressure. If we can control blood pressure, we think we can make a dent on your risk of not only stroke, but also dementia. And that adds to the message for why we need to control blood pressure. Now, the problem is, and we're going to talk about this, is that the best data indicates that the blood pressure that's important is your blood pressure in midlife. So your blood pressure in midlife seems to be the strongest driver. People between 45 and 65 with hypertension, those are the ones that are more likely to have this white matter disease, and you'll see stroke. So for the next phase of our planned outreach, we want to select this targeted audience, and it's Black men between 28 and 45 getting into this midlife, but it's also targeting Black men because they are the ones who are at highest risk for high blood pressure and stand to benefit the most from our messaging. But the midlife pressure problem is not just related to Black men, but it is worse in Black men. So that's why we targeted this. Now, this is a challenge because people in age 45 to 65 are generally feeling very healthy, and they may have high blood pressure, but they don't notice any problems, and they're not going to notice problems until they get older, but then it's going to be too late in many instances to really reverse that process that I showed you on those slides. And a lot of this data comes from the CDC or the National Center for Health Statistics on hypertension prevalence and the actual effects of high blood pressure in African-American men. We have done studies, and about 50% of the high blood pressure and 50% of the stroke risk in Blacks seems to be related to known risk factors like blood pressure, but there's also probably 50% we don't know about, and that's another area to try and understand what those are. Are they psychosocial factors related to race and racism, stress, socioeconomic factors? These are kind of things we need to look into. But we do know that at least 50% are known risk factors. Now, there's some data to look at a study that followed people. They started when they were young, age 30, and then they followed them for years. And what it shows here, this is your risk of a stroke on the y-axis, and this is the risk at different ages on the x-axis. And this is somebody who doesn't have blood pressure. There's still an increased risk as you get older, but the different levels of blood pressure. This is the highest level of blood pressure. You can see they have much greater incidence of stroke, and that differs from normals at a fairly early age. In 35, 40 already, there's a difference. And then between 40 and 50, there's a huge difference that continues. So again, good evidence that we need to start early, even as early as age 30. This is the same graphs if you're looking at the blood pressure at age 40, the message is really much the same. And here what you see is the risk of death and stroke on the y-axis and the blood pressure on the x-axis. And you can see this is lower than what would be expected. If you have really low blood pressure, your risk of stroke is actually lowered. But as the blood pressure goes up past, say, 115 here, past 120, then your risk of stroke goes up. And this is the blood pressure at age 40. So once again, evidence that it's really the problems are beginning at an early age. And from the pathology slides I showed you, you can really understand that to get to that stage would take probably decades where the blood vessel is completely blocked. So we think targeting this group is really important. And then this is, again, looking at Blacks versus white in pink, Blacks in the bluish color. And this is studying people starting at age 30 again. And you can see that as they get followed up, there are more strokes in the Black group than in the white group. And that's considerable. And that's something, the health disparity that we really need to do something about. Now, as I mentioned, this is not just a problem for stroke, but it's also a problem for cognitive impairment as you get older. So here's data from a study run out of NIH documenting that it's midlife high blood pressure that's associated with stroke, dementia, this white matter disease, and the neuropathology that I showed you on those slides. And they showed that in people who've been followed since age 30, by age 50, people with high blood pressure have actually cognitive changes suggesting they have poorer brain health compared to people with normal blood pressure. So again, this is subtle, but this is real, and more evidence that the problem is starting between the ages of 30 and 50 in this group, that they can pick it up by age 50, the effect of blood pressure on cognition, which leads us to the conclusion that the control of blood pressure in midlife may be very important in reducing unwanted early brain changes. And here you can see the data. So these are white women, these are Black women, white men, Black men, and the different colors are different levels of blood pressure. And the higher the blood pressure, the worse the cognition over time. So this is data that's staring us in the face to do something about. Now, what to do? So we've done some qualitative research to try and get the message across. And the takeaway points are that men, African-American men in this age group, are motivated and they are interested in healthy behaviors and feeling responsible for themselves and their health. But the doctor, relationship is probably not the best way to get this message across, particularly the way that message is delivered now. They prefer high impact, direct messages. They like discussions about health to take place in low pressure environments, i.e. not in the doctor's office, and to engage with experts outside the doctor's office. They have a good understanding of high blood pressure, but they don't feel much personal urgency when it comes to risk of stroke and dementia. They know about high blood pressure, but it's just not relevant to their health at that age. So the key is to indicate to them that this is really for your future health and that of your family. So the program that we're going to put out, we call it Nobody's Got You Like You Got You. Take charge of your health today, help prevent stroke and dementia tomorrow. And it's a campaign empowering men to take charge of their health because there's so many things that are out of your control. You could fall off your bike and hit your head, but you can control your blood pressure. And controlling your blood pressure today can help prevent stroke and dementia tomorrow. And this campaign is set to roll out next week. Dr. Richard Benson, who's the head of our Office for Health Equity, will be the main spokesperson. So it's great that we were able to talk to you about this. We're looking for partners to spread this message. We'll work with anyone who can help to get this message out that has, we think, large impact on health. So thank you very much for this opportunity.
Thank you, Dr. Koroshetz. You may have joined this convening because the National Forum promised that practitioners who are successful in blood pressure control will share the secrets of their success. That is where we turn now. The Executive Director of Million Hearts, Dr. Larry Sperling, will talk with two practice leaders from a Million Hearts Hypertension Control Champion, the Center Siouxland Community Health Center in eastern Nebraska and western Iowa. Dave Faldmo is a physician assistant and the quality director and medical director at the Federally Qualified Health Center. Erin Hofling is a nurse and quality specialist in the practice. Dr. Sperling?
Hello, I'm Dr. Larry Sperling. I am the Executive Director of the Million Hearts Initiative. On behalf of our team and the Million Hearts partners across our country, I am glad to introduce the Million Hearts Hypertension Control Champion Program and highlight one of our national champions. Today's Million Hearts Hypertension Control Champion is a community health center who achieved blood pressure control for at least 80% of their adult patients with hypertension in 2019 and submitted their application in the spring of 2020. Million Hearts recognized a total of 15 champions in 2020. In total, they cared for more than 200,000 patients. I'm honored to be joined today by the Siouxland Community Health Center. I'll be speaking with David Faldmo, Quality Director and Medical Director, and Erin Hofling, who's a quality specialist. Thank you both for joining us today.
We're glad to be here.
Yeah, wonderful. Thank you. And I wish we could be in person, hopefully 2022. We'd like to hear a little bit more about the great work that you all have been doing, a little bit more about your hypertension control achievements and the strategies that have worked for you. So I'm going to take you through a couple of questions, and really this is just a great opportunity to highlight your commitment and the work of your teams on behalf of the communities that you serve. As a federal nonprofit, as a nonprofit federally qualified health center, what's worked best for controlling hypertension?
Well, I think our approach is that we need to know who's in charge of the patient, who's the assigned primary care provider, and provide that primary care provider's team with the tools they need to be successful in monitoring those patients with hypertension. And so we've worked really hard over the years, and our quality programs matured and developed over the past 10 years. And And we really are at a point now where I think the teams feel supported by the organization to have the tools and the ability to really to use population health as a way to make sure every patient's watched after and cared for. So I think that's really been the key. And Erin, as our quality specialist, has played a key role in that. And she helps us organize all those efforts that we're doing right now.
Maybe tell us a little bit of background about your team there and the community that you serve.
So we are in Sioux City, Iowa. We have two clinics. One's in Sioux City, one's in South Sioux City, Nebraska, but we serve that tri-state area. So South Dakota, Iowa, and Nebraska. And we're really a blue collar town. We have a lot of meat processing plants here in the area. And so many of our patients come from that occupation. And because of that, we have many immigrant populations. We have many Hispanic, Spanish-speaking patients. We have a large Somali population here in our area. We have a lot of Southeast Asians. And so we have a really a variety of different ethnicities and cultures that come in. And it's one of the great things that I think about working here is that we have such a variety of patients that we deal with. But because of that, they need sometimes a little bit of extra help. We have full-time Spanish and Vietnamese interpreters. We have Somali interpreters. We have different resources to help give culturally sensitive care. And as far as some of the other things that we've set up, and I'll let Erin speak to that a little bit about how we work with the teams in assisting them in managing their patients with hypertension.
Yeah. I'm interested to hear a little bit more about that, Erin. In your application, it was stated that evidence-based hypertension protocols have been developed for your clinical teams there, and wanted to understand the protocols that you've been working on and, of course, the outcomes that you've been able to achieve.
You know, and Erin, maybe you could touch on the audits that we do using the protocol as a basis of the peer review audits.
Yeah, so we do peer review audits quarterly, and we grab from different comorbidities, and one of them is hypertension. They have a workflow that they kind of follow. Is the blood pressure this? If it's high, are these medications being used? Is the medication or is the blood pressure being rechecked during the visit? Let's see. Were there adjustments made in the treatment if it was high? And was the patient scheduled for follow-up at the appropriate interval that's been determined? And usually that's 4 to 6 weeks, or 2 to 4 weeks if high.
I know you also noted that a team approach is used to drive your quality work. How has that team approach helped to facilitate becoming a Million Hearts Hypertension Control champion?
So Erin will meet with each provider and his or her nursing staff, but we also have RN health coaches and behavioral health case managers that join that quality huddle for each provider. And they're able to receive a list of patients that aren't meeting goal for the blood pressure measure. And with that list, it also lists their last visit, when it was, what their blood pressure was when they were last seen. Do they have a follow-up appointment? It has their phone number. And so that has been very useful. So then after that quality huddle that occurs about every 2 months, that team has that list. And when they maybe have some downtime, maybe their providers out of the office one day, the nursing staff can use that list to call patients, make sure they have appointments, see how they're doing. Our RN health coaches are available on the spot when patients are in the office. If we need to do some education on a DASH diet, they can go in and give a patient a American Heart Association printout of what a DASH diet really is and give them oral instruction on that as well. And then, as we know, many of our patients have different barriers to lifestyle modifications, and all of our health coaches and behavioral health case managers have training in motivational interviewing. And I think that's real valuable in helping patients set self-management goals and overcoming maybe some mental blocks and doing what they really need to do to make those lifestyle changes to help address their blood pressure issue.
Well, this has been, as you all know, a very challenging year for those of us who serve in healthcare and public health and serve communities like you do there in Iowa and Nebraska. There During the past year, what have you all been able to do to keep your practices focused on controlling hypertension and making sure that cardiovascular disease prevention remains a priority?
So as you mentioned, it's been very, very difficult, and our area was really hit hard due to the occupations that many of our patients are employed in. And so for a while, we were really shut down to patients, and we had parking lot clinics. We created a drive-through testing site for COVID testing. And of course, when we were seeing patients in the parking lot, we weren't taking blood pressures. We were checking a pulse ox and a temperature. And we had so many patients that just did not feel comfortable coming into the office anymore. And so, we did start telehealth. And fortunately, a couple of years ago, we participated in an Iowa Medicaid blood pressure project that allowed us to provide home blood pressure cuffs for many of our patients. Not everyone, but some of them were able to monitor their blood pressure at home. And so when we would call them for a telehealth visit or do a telehealth visit with the tool we use to have the audio and the visual together, they were able to tell us what their blood pressure was at home, and that's helpful. But many of them didn't. We would ask them, are you having chest pain, headaches, ankle swelling, any palpitations? But we really couldn't assess where their blood pressure was at that time. So just now, some of our patients are just now coming back into the office for the first time in over a year, and many of them are not under control and probably have not been over the last few months. And so that's been really difficult, but we've really done our best to when we've had these televisits, is trying to find out if maybe they can purchase a home blood pressure cuff to start monitoring at home, and try to make sure they're getting vaccinated so they will feel comfortable coming in for a face-to-face visit so we can properly assess their blood pressure in the office. But it has been difficult. But the nice thing about the system we have set up is at these quality huddles, we know who's not been in and who's on the high list right now. And we can really work that list to make sure that we're reaching out to make sure they have appointments and we can get them in to really assess them. It's now the numbers are going down with COVID, and many are more comfortable coming into the office.
So it does sound like with your population health approach that you've been able to identify some higher risk individuals and reach out to them in a proactive fashion, which is really wonderful. You talked about the parking lot, visits when things were shut down. Any sense of the telemedicine visits, the percent of those you all were doing at some point, and where are you right now, and how are you trying to incorporate hypertension control and a checklist of some of the protocols you might use in the office through telemedicine?
Yeah, it's been difficult, and it's certainly not optimal to assess someone's blood pressure or hypertension control remotely. And so I think our main focus now is getting people back in the office and knowing that, we did the best we could with telehealth, but it's time to get them back in the office and provide a safe environment that they can come in and be seen and make sure they feel comfortable with that. And so that's really our focus right now.
Well, any last comments you want to share with the National Forum? And again, just thank you so much for joining us today for this conversation, but also on behalf of those on your team. It sounds like you're committed to the great work that you do, even in the midst of our current really continued challenges each day. My strategy's been just take one day at a time. I think that's all we can do. But any last comments you want to make? And again, thanks from the bottom of my heart. A million thanks for being a Million Hearts Hypertension Control Champion. You've taught many around the country about what it is to be a best practice. Any final comments?
I think an important area is the quality huddles and the process that we do. And I think one thing that really helps that is in each of those quality huddles, the provider team, the case manager, the health coaches, we do a PDSA, a Plan, Do, Study, Act. So we'll look at their numbers for hypertension and how can we improve that in the next 2 months. And then we come back and we reevaluate that situation. And I think that gives the teams accountability because they really want to get that number. They want to reach the goal that they set. And if we don't reach it, we kind of make modifications. Are we going to be more aggressive in our patient call reminders or calling patients before their appointments to take their medication. I think that's been huge in the process of our quality huddles.
And I would just add too that every team knows how they're performing. And so we provide a monthly scorecard on different quality measures of emphasis, and blood pressure being one of them. And they can see how everyone else is doing and how they are doing. And so it's displayed publicly back in the workstations. Everyone can see them, everyone can see how they're doing. And then for each team, we also give them a look back 12 months, each month, how they're doing. Are they getting better? Are they declining a little bit? And so, and it's not really to shame anyone, but everyone's competitive, I think. Most people are anyway. And so I think the just knowing how you're performing, no one wants to be last on that list. And so everyone works a little bit harder, and that's worked really well. The other thing is just have standardized workflows on how to properly check a blood pressure. And so every year, all the nurses have to go through a competency testing. And that's one of the stations, how to properly take a blood pressure. So that's one thing. And then just little things like, what if someone missed their last appointment and is calling for a blood pressure refill on their medicine? You know, sometimes we'll give them enough, we'll give them an appointment and give them enough to get through to that appointment. If they miss that appointment, we'll set another appointment and give them just enough to get to that next appointment. So little things like that, I think over the years, teams have learned what's the best way to help people be compliant and with our recommendations and teaching them lifestyle modifications that are helpful, so we're not only relying on medications as well. We do our best to provide fresh produce for our patients during the summer months with a collaboration we have with a program called Voices for Food, where we actually have fresh produce in our lobby that anyone can access. You know, so if we're talking to them about a DASH diet, some of them say, I can't afford that type of a diet, but you know, we do all we can to help them with that, overcome that barrier by providing fresh produce. So there's just a lot of little things that we're doing over the years that I think now is really paying big benefits and making sure that we're doing the best we can in controlling blood pressure in our patient population.
Well, Dave and Erin, thank you so much for joining us. I've really enjoyed personally learning about the work that you do and continue to do. Please extend our congratulations and our thanks to all that work with you there at the Siouxland Community Health Center, and wishing you all the best in the coming weeks, months, and year ahead.
Could I just add one more thing? I think having support at the top is crucial. So we have a chief medical officer and a CEO that are all for these quality huddles and allowing providers to be out of production for an hour to concentrate on their quality measures with their team. And so just having that support from the top is so crucial to have a successful program.
Thanks for adding that. So definitely the need for support, recognizing that quality makes a difference. And also it creates a team. It creates a team atmosphere and the right culture for success. Thanks to all of you, and really appreciate you joining us. And wishing you all the best. Keep up your great work, please.
Thank you very much.
Thank you, Dr. Sperling, Dave, and Erin. Next, we continue with Success Secrets. Meg Guerin-Calvert, President of the Center for Healthcare Economics and Policy and Senior Managing Director of FTI Consulting, will lead a discussion with two leaders who have brought better health to people in neighborhoods of Buffalo with high prevalence of hypertension. The Reverend George Nicholas is Senior Pastor of Lincoln Memorial United Methodist Church, and Maria White is Deputy County Executive in Erie County, New York. The multi-sector collaboration they lead has been successful at reducing health disparities in the community. Meg?
Good afternoon. Thank you, John. I'm really excited to be interviewing these two leaders to share their insights. And let me start, Pastor Nicholas, with you directly. Before COVID, under the African American Health Equity Task Force, you had convened and mobilized a faith-based partnership to understand the significant concerns about chronic conditions, including hypertension's the root causes, social determinants of health, and particularly their adverse effects in zip codes where the majority of African Americans in Buffalo reside. And in those early weeks of COVID, with that perspective, you met with county leaders to raise some specific significant concerns. Please set the stage for us and share what were those concerns, what was the ask of the county?
Well, thank you, Meg. You know, we had been working on the issues of health equity because there are some significant disparities between African Americans and whites in Erie County. And when COVID-19 hit the region, we knew, because we had done our work around diabetes, asthma, hypertension, heart disease, that this pandemic, this virus, potentially have a devastating impact upon the African American community. And we also knew that many of the frontline workers that were in our healthcare system, our hospitals, were people from the African American community that would be vulnerable to the spread of the disease. So we pointed that out to the county leadership and talked about how we can work in collaboration on developing a plan to meet the needs of people in those communities.
Great. And then Maria, you were sitting at the table. What did you and the county do that was perhaps unique in terms of responding to these concerns?
Well, Meg, the good news is the county was already prepared to examine the social determinants of health. And in 2019, the county executive released a Health and Human Services strategic plan called Live Well Erie, with racial equity as a guiding principle and with the social determinants of health and improving them as a goal. So when we heard from Pastor Nicholas and many of the leaders of the African American Health Disparities Task Force, we were prepared to really take a hard look at the data and examine exactly what the disparities were with regard to COVID-19. And they were alarming, Meg. And we made a commitment to report on that data publicly, to acknowledge that it was a problem, and then to work in collaboration to address it.
And I know one of the concerns that came out of that data, which was at a highly disaggregated level, was to really turn around and start to engage in some actions because you had a very, very high, unexpectedly high perhaps rate of African American mortality infection. Pastor Nicholas, can you share with the audience what it is how the partnership, the collaboration was empowered to really act and really move forward, given the data that you are seeing?
Well, we knew we had to reach out to those who had already been caring for people in the African American community. So we built a coalition that included Dr. Raul Vasquez, who has, one of the largest community health centers in the region and really is focused on working in the minority community as well as the Community Health Center of Western New York and also Jericho Road. And these folks were the folks that were already working with folks in these communities. And we reached out to the churches and we decided that we needed to contact the people in our community and give them, one, information about COVID-19, two, to do a wellness check up on them, get them connected to testing, and then discover whether or not they needed food or connections to primary care, both physical and mental care. And we literally called people. We set up call centers in 15 churches in the city of Buffalo. We hired people from the community. A lot of them were college students who were at home from college because of the pandemic. We developed a tremendous IT system, and we literally called everybody in our community. And those we didn't reach on phone, we were able to work with the National Witness Project, which is a group of community health advocates who literally knocked on people's doors in the midst of a pandemic just to find out how they were doing. And if people had concerns, if they needed transportation to primary care, if they needed to be able to get testing, if they needed food, if they needed mental health services, we were able to do that work through our navigators right there at a one-stop type thing.
And Maria, let me ask you to add more about this massive phone bank and this initiative and what the follow-on was. I know, and we've provided in the backup materials, an incredible list of partners that you brought in to add capacity, but share your insights from the county perspective on.
Yes, gladly, Meg. Our contribution to the effort was twofold. One, I would say to bring in some partners in the healthcare industry. So Kaleida, for example, is the largest provider of healthcare in the Western New York region. And we were able to partner with them who in the early part of the pandemic really had way more testing capacity than the county health department had. And because of this collaboration, because of the county's power of influence, we were able to get Kaleida to set up testing locations in the African American community at places that were recommended by the community. But the other thing that we brought to the table, Meg, was resources. And by resources, I mean cash. The county made a decision to use coronavirus relief funds to perform this kind of wellness check on our community and on people in our community that were in highly distressed zip codes and really in great need. And it was because of those resources that, that Pastor Nicholas was able to empower members of the Health Equities Task Force and the phone bankers that he's talking about to provide food, to provide mental health services, et cetera. And then just to bring on another layer to that point, Meg, as the pandemic wore on and we realized we were not just dealing with the impact of the virus, but rather of the dominoes of the virus. We used that same infrastructure to figure out how to support housing when people couldn't pay their rent, to figure out how to support childcare when people needed and were expected to go back to work, but needed childcare support. With virtual learning centers. I mean, that infrastructure became key to solving some of those other social determinants of health that really influence a person's health outcomes.
And then when the vaccines came out, we had the infrastructure in place to begin to start calling people that we had already had relationships with and to break down that vaccine hesitancy issue and turn it into access to vaccines. And where we were able to just in a 16-hour period, make 1,200 appointments for people in our community for a community pop-up vaccine center that the county was working on. So the relationship is ongoing, and that's what's so key.
And it sounds like the relationship is not just among you and the other trusted organizations and partners. It sounds like you're trusting in a way that it doesn't matter who takes credit. But what I'm hearing also, if I understand correctly, is it's using that trusted relationship to go that extra mile to reach out to the community member, to the resident who is most affected. Is that, I think, the key takeaway as well for how to interpret what you've done?
Well, it's leadership. It's putting the needs of the people in the center of the work. And the true leaders will build coalitions and will do the things that is necessary in order to make sure that the people get the service, they get what they need. And so the community, our task force, understood those issues. And so when we reached out and invited the county to work shoulder to shoulder with us, they were a willing and enthusiastic partner because it gave them a clear path on how people can get some help. And that's the key. It's the leadership and keeping the people in need in the center of the conversation. And then all the other logistical and political and whatever issues that may be, those things will work themselves out. You just have to keep the needs of the people in the center of your work. And, that's why we received the results that we did. 33% of the early deaths out of the African-American community, 2.5 times more than the population, which was going on nationally. The latest data that we had, what African-Americans make up 14% of the population in Erie County, and the death fatalities was below that rate. right? And so that's a direct response to this work.
Let me give each of you a moment to be forward-looking and to share your thinking as to where you can go forward, particularly with regard to the Surgeon General's call for hypertension.
Meg, I'll start. I really think that the infrastructure that we built was proven to make a difference on those social determinants of health. And that's not just the case for addressing COVID-19, but as we know, addressing the social determinants of health has a big impact on so many health conditions, like heart disease, like diabetes, like obesity. So all of the work that we did really produces an excellent recipe for tackling exactly what the Surgeon General is looking for our community to address now more than ever.
As you know, it's very well documented that hypertension is a major, major problem in the African American community. And that's driven by the social determinants of health. And the only way that we'll be able to successfully address the issues like hypertension and other chronic diseases is by tackling the social determinants of health. And the only way that we can be effective in that is to do it through partnerships. The Black community can't do it on its own. The business community can't do it on its own. Government can't do it on its own. Universities can't do it on their own. There has to be a real, a sincere working relationship and working plan to address the social determinants of health. And then we'll see the same kind of results we saw here in Buffalo with the dropping of those fatality numbers. I'm very confident that we can impact any chronic disease with this same kind of collaborative work.
My heart is with you. Thank you so much, both of you.
Thank you.
Thanks.
Thank you, Meg, Maria, and Reverend Nicholas. Now we turn to two individuals who are passionate about self-measured blood pressure and improving cardiovascular health. You probably know Janet Wright as the first executive director of Million Hearts, or perhaps as the senior scientific advisor to the Surgeon General of the United States, or as senior vice president of the American College of Cardiology, or the current acting director of CDC's Division of Heart Disease and Stroke Prevention. Maria Prince is medical director at Aetna. She has served as the flight surgeon in the U.S. Air Force and as medical director for chronic disease prevention in Maryland's Department of Health and Mental Hygiene. Doctors Wright and Prince.
Hello, Maria. It's so wonderful to reconnect with you.
I know, it's so great to see you after 10 years.
We have been in the salt mines of hypertension control and really self-measured blood pressure monitoring for, like you said, a decade. I want you to share with our audience today what Aetna has done to help more people get access to and learn to use the evidence-based approach to blood pressure control, which is SMBP.
Sure. When I came to Aetna 5 years ago, I was absolutely thrilled that our clinical policy folks were on board with the U.S. Preventive Services Task Force recommendation for self-monitored blood pressure. I didn't have to make any big detailed evidence-based with a return on investment. They simply looked at the clinical guidelines and it was a no-brainer, is what they told me. So we were able to incorporate that into our clinical policy to support coverage of home blood pressure cuffs for the diagnosis of hypertension. And then later on, we subsequently added it for the management of hypertension. And that policy applies to commercial members, so members in private insurance, as well as members in Medicare through their over-the-counter benefit.
It's fantastic. And I know that it wasn't exactly pushing on an open door, but what I hear you say is that they followed the science, they followed the evidence. And that's what I think is, right. It's the strongest foundation. It's certainly what CDC believes in doing, is letting the science lead. And the policy has followed. that is a huge hurdle for Aetna members. And I think one thing you and I would advocate for is that all payers, commercial and public, follow suit, right? Follow the evidence and broaden that coverage. But with that accomplishment, there are still additional hurdles to overcome. Could you speak to those and think in terms of our National Forum members and how they might play a role?
Sure, absolutely. I think this is important for every one of you who might be listening to this. I've been lurking on this National Forum meeting for more than 10 years since I was a resident, and I've been in different settings, public health, primary care, and now with an insurance company. And I know that there's a role for each of you, no matter where you might be. So, now that we've had this coverage, I know that not every clinician is even aware that we have this coverage. So we appreciate your assistance in letting clinicians know about it and also letting payers know about it, because we've found that clinicians, obviously, we can't remember everyone's policy. So let's make it a no-brainer for them and make sure everyone has this policy. There should be coverage for self-monitoring of blood pressures, no matter if you're in private insurance, government-sponsored Medicare, or Medicaid. And I personally took that next step by reaching out to my Medicaid colleagues to make sure that their coverage policies were looking at home blood pressure monitors as well. And the other group that we're trying to reach are our patients, our members. So we're doing some really unique omni-channel marketing to outreach our patients so that they're aware of this coverage. And then every time I meet with a plan sponsor, that's another opportunity I have to talk with employers. I'm always reminding them of our unique coverage. And if you're from another payer, you also want to be having this coverage as you review their high cost claimants, and you're talking about all of the conditions that they're concerned about, the heart failure that needs heart transplant, the stroke, the kidney disease. You can remind them that this is all preventable, literally a no-brainer. We've known about this since really the 60s, and now 60 years later, we should be doing this for everyone.
So thanks, Maria. When I hear you saying there's a cuff in every household and people know how to use it and they're connected to care, and we have a sustainable system. So you and Aetna have put us well on that path, and we ask all National Forum members to find out what they can do to make sure everyone across the country who wants one and needs one has access to a cuff and is connected to care. Thanks so much, Maria.
Thank you, Dr. Wright and Dr. Prince. Your passion for prevention is infectious. Now, we will take a 5-minute break. Don't go too far away, because when we return, the National Forum Senior Program Manager, Jen Childress, a certified personal fitness trainer and coach, will lead us in a short physical activity.
Hey everybody, I'm Jen Childress. Thanks so much for joining me. For the next 2 minutes, I invite you to get up and get moving. This video won't have any cues, so just follow along and copy what I'm doing. Make sure you have some space around you, and let's have fun and do this. Let's go.
Thank you, Jen. That helped loosen me up and increase my attentiveness. Mental health affects cardiovascular health and well-being on a scale that is disproportionate to the amount of attention it receives. Our next speaker, Bernadette Melnick, will help us raise the priority on diagnosing and treating stress and anxiety as part of our formula to improve hypertension control. Dr. Melnick is Dean of the Ohio State University College of Nursing, University Chief Wellness Officer, and she holds a host of other faculty and leadership roles at OSU. Among her many external leadership roles, she is Secretary-Treasurer of the National Forum. Reading Dr. Melnick's impressive bio sketch is exhausting, but inspiring. I urge you to do so. Now, Dr. Melnick.
I am delighted to be with all of you today. I am going to make a strong case with evidence on why we need to be incorporating stress and anxiety to a greater extent in the prevention and management of high blood pressure and cardiovascular disease. I've got a philosophy in God we trust, but everybody else better bring data to the table. So I'm going to bring you quite a bit of evidence today. Before the COVID-19 pandemic, 1 in 5 adults were living with a mental health disorder. Now I say we've got a mental health pandemic inside of the COVID-19 pandemic. An MMWR report found that symptoms of anxiety disorders were 3 times those reported in 2019. And symptoms of depressive disorders were 4 times those reported in 2019. Higher rates of heart disease as a result of pre-existing mental health conditions are seen in veterans, women, couples with someone who has PTSD, and racial and ethnic underrepresented populations. The other thing we're seeing across the country right now, people are attempting to cope with the stress of the ongoing pandemic with unhealthy lifestyle behaviors. Drug, alcohol use is up, unhealthy eating is up, and physical activity is down. that is all going to have an adverse effect and contribute to more cardiovascular disease. So both long-term and short-term stress can play a role in the development, onset, and progression of heart disease. After an acute stressor, we know there's a cascade of changes in the cardiovascular, nervous, endocrine, and renal systems. Chronic sympathetic nerve stimulation of the cardiovascular system leads to persistent elevation in blood pressure, vascular hypertrophy, and plaque formation. This was a wonderful systematic review and meta-analysis. 11 studies were included with 5,600 participants. The authors found that psychosocial stress was associated with an increased risk of hypertension. We did a study at Ohio State. These people were screened as part of our Million Hearts Fellowship program. Compared to those individuals with low stress, controlling for a bunch of demographic variables, high stress was associated with significant higher risks of having pre-hypertension and hypertension. Another meta-analysis included 8 high-quality studies with over 950,000 patients. Anxiety disorders were associated in this study with a 24% increase in risk of strokes. We really need to screen for, identify, and offer brief evidence-based interventions to our patients, specifically for stress and anxiety. Many people underestimate the effect stress has on their bodies. This is a wonderful handout to talk about a 4-step approach about stress with our patients. Ask and listen, talk and screen, offer suggestions, and I've modified that a little bit to offer brief evidence-based strategies to cope with stress, assess, and adjust. We really have to get into the habit of screening, asking our patients about stress and how they cope, and is it effective or could they use to improve? We need to screen diligently for stress, anxiety, and depression. However, there are still many providers across the country who do not routinely screen for stress, anxiety, and depression. We've got fabulous, brief, valid, and reliable tools to screen for stress. The perceived stress 4-item scale, for example, anxiety with the GAD2 and depression with the PHQ2. Screening does not equate to diagnosis, but it certainly raises a red flag that should be further evaluated. I always recommend the use of ESPER, screening, brief, evidence-based interventions, and referral as indicated to treatment. Well, there are quite a few brief, evidence-based interventions that we know through research help to reduce stress. For instance, deep abdominal breathing using the 4-7-8 method. Breathe in, count to 4, hold it for 5, breathe out for a count of 8. That cuts off the sympathetic nervous system, lowers blood pressure and heart rate. We need to tell our people that even 11 minutes of physical activity a day has heart health benefits. Another very brief, simple practice that has tremendous cardiovascular positive effects is a daily dose of vitamin G. For gratitude, if we could get up every morning, count just a few people or things we're grateful for, do that as we go to bed at night. That would cut stress and improve mood. Learning how to stay in the present moment, learning cognitive behavioral skills that I have taught with success for years in my COPE program, because the root of a lot of stress, anxiety, and depression is how we think. So we need to help people catch, check, and change their automatic, unhelpful thoughts. Lastly, we need to continue to assess and adjust as necessary, but partnering with our patients and providing ongoing support to help them learn to more effectively handle their stress and anxiety will go a long way to promoting cardiovascular health. So I'm going to put forward a few proposed solutions. We need to advocate for reimbursement for stress and anxiety screening and the provision of brief evidence-based interventions. Nurses could be doing this so effectively in primary care. We need to leverage community health workers. They can play such a key role in screening for stress, anxiety, and providing evidence-based interventions, especially in underrepresented populations. Lastly, we have got to emphasize SBIRT for stress, anxiety, and depression in health sciences educational programs, as well as prevention and early evidence-based interventions, including healthy lifestyle behavior change. So I'm going to finish by asking you to join us in our Mask On, Mood Up movement. Every time you put on your mask from now on, I'm going to ask you to take 3 deep abdominal deep breaths using the 4 or 5, 7, 8 method. Be kind to yourself. Say a positive self-affirmation statement 10 times. Research shows that does help to decrease stress. And lastly, take that dose of vitamin G every day. When you put on the mask, think of somebody you're grateful for. Turn around, call them, email or text them, and tell them why. Together, we truly can make a difference and improve the cardiovascular health of Americans. Thank you.
Dr. Hardy Davis Jr. is mayor of Augusta and a former member of the Georgia House of Representatives and State Senate. While Augusta has notched impressive economic development results under Mayor Davis's leadership, helping Augustans to live longer, healthier lives is also a major priority for the mayor. He uses the National Forum's Move with the Mayor platform to encourage Augustans to be physically active and to educate the public about blood pressure control and protecting themselves from COVID-19. Dr. Davis has a certificate in health policy from Georgia State University. Mayor Davis's fellow mayors recognize him as a leader. They have elected him president of the African American Mayors Association and trustee of the U.S. Conference of Mayors. I call him Dr. Davis because he earned his Doctor of Ministry degree, and in addition to serving as mayor, he serves as senior pastor of Abundant Life Worship Center in Augusta. Today, we are pleased to talk with Mayor Davis as a champion for health equity and cardiometabolic health. Mayor Davis, welcome.
John, thank you so much. I really appreciate the partnership that we've been able to form over this past year with the National Forum for Heart Disease and Stroke Prevention. You guys have been incredibly responsive and supportive of our efforts here in Augusta, Georgia. And I couldn't be more proud than to help champion this cause around the Surgeon General's call to action around hypertension.
Well, that's great. We really value the collaboration with you and your team, Mayor Davis. Mayor, why is blood pressure control important to you as a mayor?
Well, it's important for me, one, because of my concern for all of our residents, some 204,000 residents that make up the city of Augusta, but from a personal perspective, as someone who's been challenged with hypertension from my days in the legislature. I remember it vividly like it was yesterday, me making my way back on a Monday morning to the legislative session, final days of the 2008, quite frankly, legislative session, my second year in the legislature. And I remember making my way up I-20 and feeling this tightness in my chest and not knowing what it was and really what was going on. I did the first thing that most sons do, and I picked up the phone and called my dad. And my dad says, well, you know, is it this, is it that, or the other? And I made my way on into downtown Atlanta to the Capitol. And as I went through the course of that morning, my seatmate recognized that I looked flush in the face, and he was concerned. I went down to the doctor of the day, and the next thing you know, I've got a blood pressure of 220 over 160, and I'm trying to get through day 37 of the legislative session. And I went back up and, thought I'd feel better. And my seatmate looked at me again and said, I'm going to get the doctors. I'm going to get state troopers. And they rushed me to the hospital. Little did I know at that time I was diagnosed with hypertension. And I've taken a low dose of meds from that time. What it caused me to do, John, was to really focus on my health. Not just from a hypertension standpoint, but just overall, my diet, my weight, and all of those factors that play a role in blood pressure. So this is extremely important to me, not just from my care and concern for the citizens of Augusta, but most importantly, my own personal health and well-being, so that I'm able to live a long, healthy, and prosperous life.
And how, Your Honor, how does your personal experience and the concern for people's health that has given rise to, how do you tie that into the commitment that I know you have to health equity?
Well, that's extremely important. I mean, when you look at communities like Augusta all across this nation, you want to, especially in this COVID environment, we've seen the challenges around healthcare, the issues of health equity, particularly around access to quality and affordable healthcare. Those are longstanding issues in communities of color, Black and brown communities. When you look at the challenges associated with those comorbidities around the virus, they are systemic and chronic in communities of color. And so for me, as a champion for health equity, it was extremely important for me to not only launch Move with the Mayor in our city, but look for ways to bring people into a broader conversation about our overall health and well-being. As a champion for that, personally, but professionally, and wanting Augustans to live a healthy life, I know how important it is to bring that entire healthcare continuum to the conversation and the table, quite frankly. And in this instance, to the walks and the exercise things that we've done, because so many times people become sedentary in their life. They go from one job to the next. They find themselves working in the public sector or private sector, and they become sedentary in nature. And so for me, I wanted to look at that entire healthcare continuum. What is our role as individuals? What is the role of the healthcare community? And what can we do as a city to promote wellness and healthy living in a way that's creative, fun, and quite frankly, constructive, but it's a way for people to connect around common issues in a way that they don't have to be afraid of this thing called high blood pressure and all of the historical implications of what we've heard and seen. I mean, high blood pressure can lead to strokes. Those are real issues. And so for me, we've been able to have a conversation or a series of conversations in a way that I believe have proved fruitful, but also bring equitable matters to the table of how people can get the access and the care that they need.
Mayor Davis, we know that you are leading in Augusta, and we know we have folks from over 100 organizations spread all across the United States who are listening to us right now in this convening. And I'm hoping that some of them will be able to take things that they hear from you and put them to work in their communities. And I know as well, as president of AAMA and as a leader of the U.S. Conference of Mayors, you have other mayors seeking advice and ideas from you. So when you take what you know about advancing health and health equity in Augusta and offer advice to your fellow mayors, what are the top 2 or 3 suggestions that you have that you can share with them for how they in other communities can help raise awareness of the importance of, say, hypertension control and of taking charge of one's own health? And then how, as a mayor, you can not only provide that communications and leadership, but also advance policies that will make it easier for people to do those things in their lives.
Absolutely. You know, for me, I think about the positive power of mayors leading by example across this country. My good friend, Steve Benjamin, just down the road in Columbia, South Carolina. I think about Mayor Sharon Westenbroom. I think about all of those other partners that we have who have engaged with the good work that's being done by the National Forum. And I think about, for me and them as well that I just mentioned, of how we've been able to leverage our platform called the Office of the Mayor and have convenings. So in cities all across America, you can begin with a commitment to your own personal health and well-being. I think everything starts there, leading by example in terms of how you take care of yourself. It's not enough to just exercise, but you have to have a good diet and really being willing to share that with people from all walks of life, and then looking for ways to bend that arc into the healthcare community of where we bring those healthcare providers who take care of us into the conversation. I'm very fortunate to have one of the chief cardiologists in the nation as my friend, but also my doctor, Dr. Mac Bowman, who's a champion for all of the things that we've done with Move with the Mayor. He's led that conversation with me to include having a very broad conversation about the challenges associated with the virus and how it attacks people's health system. And so when you can, one, leverage your role as mayor and take the pulpit that you have available to you to talk about your own personal health and wellness, and then bring that conversation to those healthcare providers who we enjoy the benefit of having access to, and then taking those same healthcare providers, thirdly, into the community because they want to give back. They want to make investments in their own communities as well. You cannot lose sight of those types of opportunities. And I think, fourthly, knowing that if you live in a community where there are research institutions or institutions of higher learning, how do you bring them into the broader conversation as well, especially for those that are children at younger ages? I think about just a year and a half ago, almost 2 years ago now, of where I partnered with our local university, Augusta University, in competing for one of the grants through the U.S. Conference of Mayors for childhood obesity and health. And so we were very fortunate to win as a mid-sized city. Those types of conversations of where we're able to go into daycares, go into the child care facilities and centers and talk about what is it to prepare healthy snacks, healthy lunches, healthy meals for children so that they don't develop those comorbidities at an early age. We've found that to be very important for us in Augusta, so that we are trying to address these challenges across the entire life cycle of individuals, not just when you get my age and where you're starting to be concerned because somebody told you you had hypertension. Those are things I would encourage people to do.
Terrific. Thank you. And I know you certainly are a champion for economic development in your community. You've talked about being a champion for health and for health equity. I believe one of the concerns that you have and that you've addressed in Augusta is food security. And I know from our conversations at other places that you connect those dots. Those aren't siloed issues for you. They come together. Can you speak? We only have about a minute left, but can you speak, Mayor Davis, to how those dots connect and why, say, the health of Augustans is important to the economy of the city?
Without question, health and wellness is, in fact, economic development and growth. If you do not have a healthy, stable, and viable workforce, it's very difficult to move communities forward. When you look at Augusta's health stats, again, just for around cardiovascular disease, 241.3 deaths per 100,000 compared to the average across cities of 211. We know we've got work to do. And so who better to champion that cause than the mayor? I can tout Augusta's tremendous success around economic growth and development, leading the state, quite frankly, the last several years, even during the pandemic. But the success of that really largely is tied to how do we take care of people? How do we present them with healthy options, not only around eating, but where there's food insecurity? How do we go beyond just popping up, stores that are fast food in nature, which we are happy to have them in our communities, but people need healthy food choices. We've restarted the market, the Saturday market here. We've also got a market that we've partnered with the American Heart Association to have that provides fresh fruits and vegetables in the community, as well as canned goods that are fresh in nature. And so these things are extremely important to us. And I would encourage communities across America and our fellow mayors to look for ways to do those same things because food insecurity is a challenge, not just in Augusta, but across this country. This is something we can win, and especially when we've got the support of the National Forum and your team, John, have been very helpful in providing us with data sets where we can make those investments in our community. And so I want to applaud you and thank you for this continued relationship.
Well, thank you again, Mayor Davis. It's really a pleasure to collaborate with you and your team. Hardy Davis Jr., the mayor of Augusta, Georgia, a champion for cardiovascular health, a leading participant in Move It the Mayor, and perhaps most importantly, a champion for health equity. We thank you, Mayor, for your work, and we thank you for joining us today for this conversation.
John, thank you so much, and I look forward to seeing you soon.
Now, we are pleased to have representatives of 2 National Forum members who will fill us in on new developments in their organizations. First will be Juliana Crawford, Senior Vice President of the American Heart Association. Juliana also serves on the National Forum Board of Directors. She will be followed by Andrea Sharkey, Project Manager at the New York City Department of Health and Mental Hygiene, who manages the National Sodium and Sugar Reduction Initiative. Juliana?
All right, I'm really excited to be here and talk to you just briefly about the American Heart Association's commitment and goals in our high blood pressure work. We're really focused on 4 areas to address high blood pressure control across the country. The first being to continue our partnership with the American Medical Association that we all know as Target BP. We are working in about 1,000 clinics across the country to improve the high blood pressure diagnosis and control in clinical settings from a quality improvement perspective. Secondly, we're supporting access to expansion of blood pressure monitoring services across the country through public policy efforts and efforts with private payers. We've had a lot of great wins in this area in the past year or so with reimbursement codes out there for providers' time to be using self-measured blood pressure readings in their patients' treatment plans. And we really want to expand awareness of these efforts and expand utilization of these efforts in the clinical setting. Thirdly, we're really focused on supporting our communities through our work with federally qualified health centers. Again, this is really taking what we've learned through Target BP and healthcare organizations across the country and adapting it in models that really work well for federally qualified health centers, while also addressing social determinants of health that patients in these centers are facing, like food insecurity. And then our last strategy is really around working with community-based organizations such as faith-based organizations or in workplaces where these types of settings can also support self-management skills like self-monitoring of blood pressure and connecting members of the community to care in their community. I also wanted to share a really exciting announcement that was made in December. The Department of Health and Human Services, and specifically the Office of Minority Health and HRSA, did award the American Heart Association a cooperative agreement to work in 350 health centers across the country to really bring these strategies to life. The goals of this initiative that we're calling the National Hypertension Control Initiative is to first and foremost establish a nationwide approach to addressing hypertension and other outcomes as a result of COVID-19, specifically for populations most at risk. So racial and ethnic minorities, American Indians, Alaska Natives, and other vulnerable populations in rural communities. Of course, we want to improve health outcomes, specifically blood pressure control. There's a big part of this effort will be focused on increasing the use and advancing the use of self-measured blood pressure technology in health centers and throughout the communities for patients, increasing awareness and utilization of health programs and community services that can support patients, and increasing patient and provider education and training. The initiative is for 3 years, and beyond the cooperative agreement awarded to the Heart Association to do this work, there is an additional $60 million coming from HRSA to support these health centers in terms of efforts like stipends to do the work, purchasing of blood pressure monitoring equipment for their offices and for their community as well. And then finally, there's four major strategies involved in this effort, and you heard a little bit about that. The first being patient and public education. And in this first year of the initiative, we're focused on launching a national public service awareness campaign that will really continue to elevate awareness and education of high blood pressure, and specifically the practice of self-measured blood pressure and how that can play a role in your treatment plan. We'll be working in across communities and events that can target and reach high-risk groups, and we'll be engaging communities specifically around messaging regarding those risks, and then how communities can really support those self-monitoring techniques. With our healthcare organization and healthcare providers, of course, we'll be working in those 350 health centers to bring the evidence of target blood pressure to life, to transform practices and support healthcare providers in training and skill building. Community outreach and integration will be focused on our work with community partners to ensure we're reaching their patients, their people that they serve in the community with culturally and linguistically appropriate resources, and that we're bridging the community setting to the clinic, really creating those linkages where community members can see that the health center is there for them and they can transition in and out of those settings more seamlessly. And then finally, as with any effort like this, there is a robust project evaluation and management component. And so we will have a robust and rigorous evaluation plan that will help us determine what is working best in all of these areas, so we can not only improve blood pressure control in these 350 health centers, but then spread those lessons learned across the country, so we can really impact health centers all across the country and bring those lessons to life with other stakeholders we're working with, such as the American Medical Association. Thank you.
Hello, everybody. My name is Andrea Sharkey, and I'm a project manager with the New York City Department of Health and Mental Hygiene. Today, I'll be providing a brief update on the National Salt and Sugar Reduction Initiative, or the NSSRI. The NSSRI initially started as the National Salt Reduction Initiative, or the NSRI for short. At this point in time, we were focused only on sodium reduction. The initiative started in 2009 and was modeled off of an initiative from the United Kingdom. The New York City Health Department launched the initiative and convened a partnership of organizations from across the country. The partnership has grown to include over 100 organizations who have come together to make one joint ask of industry to create a healthier food supply. We're proud to have the National Forum as one of our members. The aim was to reduce sodium in packaged and restaurant foods as a way to reduce sodium intake and ultimately reduce the risk of heart disease and stroke. Working with industry, we collaboratively set sodium reduction targets for 62 packaged food and 25 restaurant food categories for 2014, 2012, and 2014. 28 companies ended up committing to reduce sodium as part of the NSRI. We analyzed changes in the food supply over time and observed that sodium density declined by 6.8% from 2009 to 2015. Since then, the FDA has released draft targets for sodium reduction in the food supply. With this interest from the federal government, we decided to shift our attention from sodium to sugar. The NSRI has since become the NSSRI. We announced that the initiative would be expanding to address added sugar in 2018 and release draft categories and targets. That kicked off a 2-year process to refine these categories and targets, which we did by soliciting feedback from industry. This past February, the NSSRI released voluntary sugar reduction targets. We released targets for 15 categories of foods and beverages, which account for about 60% of sugar in the diet. Categories include drinks, grain-based desserts and snack bars, refrigerated and frozen desserts, candies, cereals, condiments and toppings, and yogurt. We're asking companies to meet the targets by 2023 and 2026. For most categories, targets are set to be a 10% reduction by 2023 and a 20% reduction by 2026. except for sugary drinks, which we're asking for a 40% reduction. We'll assess progress against these targets over time. There is an opportunity for companies to publicly commit to meeting these targets. Companies can work toward meeting the 2023 and/or the 2026 targets in one or more category. A big part of this initiative is evaluation. The New York City Health Department will be leading efforts to monitor progress against the targets over time. We'll be tracking progress on the overall food supply and also at the category level. We're excited to share these targets publicly as guideposts to be used by the public health community, academics, and advocates, and to be used by industry, even if a public commitment is not possible. More information about the targets and our work on sugar reduction can be found on our website at www.nyc.gov/health/NSSRI. Thank you.
Juliana and Andrea, we're excited about those developments at AHA and NSRI. Now, Dr. Ileana Pina is recognized throughout the world as an expert in preventing and caring for people with heart failure. She is a professor of medicine at Wayne State University and clinical professor at Central Michigan University. She also serves as senior fellow to the Food and Drug Administration's Center for Devices and Radiological Health. She chairs the American Heart Association's FIT Committee and serves on the National Forum Board of Directors. Dr. Pina?
Hello, everyone. You have heard some incredible talks today about hypertension. It is amazing to me, after so many years of being a cardiologist, specifically a heart failure cardiologist, that we're standing here talking about hypertension today in 2021. How come? Well, you know, I've been telling patients for years actually, that if I could control their blood pressure, I could reduce their heart failure by 50%. But I never had the data to show it. But now we have the data. How simple it sounds that getting that blood pressure down could really impact the incidence, the prevalence, and the outcomes of what I do for a living, which is heart failure. And this is not one syndrome that we don't have drugs. We have tons of drugs. They work, but the patients have to take them. And I think our jobs are to know about it and to deal with it. And I will give you a very personal example of how hypertension really has hurt me personally. One of my best friends, a highly successful veterinarian who counseled my daughter, who is now a veterinarian, on her career path, was getting an MBA. She lived in Utah. Came to see her mother in Miami. We're both from Miami. I've known her since she was 17. And putting her mother to bed and helping her with her night clothes, she just collapsed. Never woke up again. Her blood pressure was 240/120 when EMS arrived. She had a deep cerebral bleed. And once I saw a picture of the MRI, which her neurosurgery physician sent me, I knew she wouldn't make it. And sure enough, she died a week later. Our conversations came about donor for organs, about when to turn off the ventilator. And this is deeply personal because as we went back through her medical records, I had no idea that she was hypertensive. And in fact, she was. Her GYN had noted it, not done anything about it. Another internist had told her that her blood pressure was high and that she needed to take lisinopril, was what he recommended. She never did. And on a more personal tone, never told me, one of her best friends, I saw her every year at her home. I would stay with her. She never told me she had hypertension. But she was taking an aspirin every day, thinking that she was going to prevent something, and lots of vitamins and minerals. So this was not a lack of access person. This was not a person with no health literacy. This was a physician of veterinary medicine, highly successful, super insured, smart as a whip, accomplished, didn't take this seriously. So if you want to use my story to tell your patients, your family, your circles, your societies, tell them Let's get this done. The National Forum has been so bold today to push for a call to action. I want to push you a little bit more. Thank you for being here.